for joining us. My name is Barry Erickson, and I'm Community Engagement Coordinator here at Wheaton Public Library. Tonight, we are delighted to bring you this program about neck and back pain relief as part of our ACES series. ACES stands for Aging and Caregiving Engagement and Support. This program series provides a consolidated source of reliable local information and engaging programming for our community's older adults. Today, we will learn effective strategies to treat pain and prevent future occurrences from Dr. Joshua Lederman of Lederman Chiropractic and Sports Medicine. He will discuss the McKenzie Method and how it can be used for rapid, long-lasting neck and back pain relief. Thank you so much for being with us tonight, Dr. Lederman.
Thank you very much. Very happy to be here with all of you. And I'll be talking about, as she said, treating neck and back pain using the McKenzie Method. First, I'm going to give you a background, a little bit about me. So right here we have my soon-to-be 2-year-old Lizzie, my wife. My wife actually practices at the office with me, 2 chiropractors together, and we have an office located in Wheaton. A little bit more on my background. I grew up in Oswego, Illinois. I went to the University of Illinois at Urbana-Champaign to get my bachelor's in kinesiology. And then I went to Logan University in St. Louis, Missouri to get my chiropractic degree. And I also got a master's degree there in sports rehabilitation, hence the chiropractic and sports medicine in the name. I became a small business owner, and along with being a chiropractic practitioner starting in 2019. I had practiced as an associate at a variety of different offices, which prepared me to take on the new challenge of being a small business owner in 2019. I took over the practice is called McAndrews Chiropractic Clinic. And in 2021, I officially changed the name to Lederman Chiropractic and Sports Medicine. There's a picture of our office. We're located in South Wheaton off of Butterfield Road. All right, so what is the approach that we use at our office? This is really our guiding principle. We guide our patients with effective strategies for pain relief so that they can get back to the activities they love. What does that mean? That means that when you come in to see us, we're going to give you your own remedies to get rid of your pain. We're going to guide you in that process. Ideally, you have your own strategies after you've seen us so that if you have a future episode, you know what to do. You don't feel hopeless. You don't feel like you don't know what to do. You feel very prepared. In fact, you feel empowered. And so hopefully after this presentation today, you just have a good idea of kind of where to start in the process if you are dealing with neck or back pain, and then if you have it in the future, what to think about trying to do. So just a little background on back and neck pain before we get into the McKenzie Method. It's very common throughout life to experience neck or back pain or both at the same time. You can have both at the same time, or you may have one at one part of your life, and then later on in life may have another one. Chiropractors can get back pain and neck pain too. I was painting a room a couple weeks ago, and we're working on the ceiling and looking up prolonged. I had some neck pain, and luckily I knew what to do for it, and I'm on the mend. But we can all get it. So pain generators in the spine, different sources in your body that can contribute to your pain include the facet joints. That's a joint that's like between the vertebrae. Most people have heard about the intervertebral discs. The disc is a common source of pain, and then the nerves. The nerves are what sends the signal to the region. So you could have a joint causing pain, and it would send pain along a nerve route. That's why you get the term pinched nerve. Again, feel free to ask any questions throughout. If anything I'm saying is confusing, I'm happy to answer that question right here and now. I don't want you to be confused as we're going and continue to get more and more confused as I go deeper into the topic. So risk factors for back and neck pain include a history of spinal pain. So if you've had back or neck pain in the past, that can be a predictor that may mean that in the future you may get another episode, which again talks about the idea. If you have some ideas about what to do when you have an episode, then you're thinking, okay, I might get a back pain episode or a neck pain episode in the future, but you know what? I've got some things I can do if that does happen. I feel prepared. Sedentary lifestyle. Sedentary is basically just not being active. There's different forms of activity. There's physical activity and there's exercise. Physical activity, the difference between physical activity and exercise is physical activity is planned, is just, I'm sorry, let's start that again. Exercise is planned physical activity. Exercise is you purposely go and you go to work out. Physical activity is things you just do normally. You go take out the trash, you're going up and down the stairs in the house to do laundry or something like that. Yeah, you're being active, but you're not doing it for the purpose of exercise. Okay, so being active, whether even gardening, a lot of times as people get older, that ends up being something they do, and they maybe forget that's actually a really great form of exercise. So just being active can be something you can do to prevent some onset of back pain in the future. Mental health disorders. Okay, so depression, anxiety. The latest model when it comes to pain is called the biopsychosocial model. That's a lot of words in there, but basically what it means is that there's an interaction between your mind and your body. If you're feeling down, you're feeling anxious, you may get some neck or back pain. The stress may go to that region of your body. Conversely, you have back or neck pain, especially if it starts to become chronic, it can start to affect your mental health. You can start to get sad and depressed because of the impact of the back or neck pain on your life, the things you're having to modify, restrict, not being able to do. So those are just some of the factors, and we talk about on here. I talk about quality of life. So you know sometimes pain can get minimized, but it's really about how it affects your life. The things you're not able to do, you talk about where I'm at in my life right now. Like I've got a almost 2-year-old daughter. If I was in so much pain that I couldn't lift her up or I couldn't play with her, that would be devastating. And so it's just about what these things do to your quality of life. That's how pain can be. It's a very large cause of disability because it can affect work, it can affect at home. So bottom line is there's things we can do for this. Treatment options. Okay, so what are things that, places and things that people can go to treat their back and neck pain? So chiropractic care, obviously that's something I do. Physical therapy, that's another option. Some chiropractors do some physical therapy kind of stuff. Some physical therapists do some kind of things that traditionally chiropractors would do. So there's some similarities in terms of what you can get when you go to see chiropractors and physical therapists, especially as I talk later about the McKenzie Method. If a chiropractor or a physical therapist does the McKenzie Method, they may have a similar mindset to how to approach pain. Medications, injections. I didn't mention on here, I talked about the biopsychosocial model. I talked about mental health. Treatment options include a lot of times I'll see someone for back or neck pain, and I notice the impact it's having on their mental health. Some sadness, some anxiety, depression, so on. Mental health, behavioral health is so important too, and so I should have included that on the slide. But that's something where you can kind of co-manage someone. They're seeing you, and then they're also seeing a mental health, behavioral health provider concurrently, and that team approach is really great. And the same thing goes with sometimes people are seeing a physical therapist, seeing a chiropractor. Often they're maybe they're getting some prescription or over the counter medications in conjunction. Sometimes even you're seeing them and they got an injection. Oh, well, they respond better to your care because they got an injection. Because there's less, maybe they get a steroid injection or something in their back or their neck, and there's less inflammation. what do you know? They respond better to doing some exercises, to doing some conservative care. Surgery, finally, surgery. That's a lot of times that's the last option, after you've done all kinds of stuff. Depends on what's going on. Sometimes people are so far gone that they're having weakness, to the point where if you don't get an intervention right now, you don't get a surgery, it could be a permanent strength loss or permanent sensation loss, something like that. So it just really depends on what's going on. It's all about getting the right patient to the right provider at the right time. And so that's part of the evaluation process is this patient getting better? Are they in the right place? If they're not getting better or getting worse, should we get imaging? Should we refer this patient to another provider? It's always important to do that. All right, so that brings me to the McKenzie Method. McKenzie Method, we love using McKenzie Method in our office. In fact, if let's say I've seen a patient and they're moving to another area, they're moving to another state, and they go, I want to know, is there someone you can refer me to? I often I'm looking, where are some McKenzie Method practitioners in that area? I'm able to do that. I'm able to look up their zip code and I can see which providers are certified in this method. This is a method I'm certified in. I had to take additional training to get certified in this method, and it's really cool what you can do with it, especially from a patient empowerment standpoint. Just feeling like you have your own strategies. The saying, you could give someone a fish, or you could teach them how to fish. So this method is all about teaching you how to fish. Okay, teaching you your own methods to get better. So as the slide says, it's not just a treatment method. That's an important point with this. It's used to evaluate a patient based on the things that make a patient better or worse, based on their history, based on the way you watch them move in different positions. It can tell you the best way to treat the patient. So I always like to say McKenzie Method never fails, because it's going to tell you what the best way to treat the patient is. Do they need to be given this particular exercise? Do they need to do this? Are they not going to respond to movements and positions? Do they need an injection? These kind of things. Is the pain coming from musculoskeletal sources, or is there some inflammation in the body where it's not going to respond? So it's very useful in terms of diagnosing and then knowing where to go with treatment. So often when you see a provider, they're asking you things that make your pain better or worse. They, ask you, and you're thinking like, why are they asking me this? Well, there's a method to the madness with this. There's a really every position that makes you better. Okay, what position are you in when you're better? Every position that makes you worse. Okay, what position are you in when you're worse? That tells us how to treat it. I got this in bold over here. It says rule out the spine. Okay, so what does that mean? In a nutshell, you got any pain in your extremity, you got elbow pain. Someone comes in, they say they got tennis elbow. Okay, well, and I think to myself, okay, rule out the spine. Is that elbow pain? Is it from the elbow, or is it from the neck? You want to rule out the spine first, because you want to make sure you're treating the right structure. Someone that gets, sometimes it's pretty self-explanatory. Someone has pain in their back and it radiates all the way down to their leg, sciatica kind of thing. Well, a lot of times it's easy to see that connection, but sometimes you got pain and you think it's one structure and it's actually coming from another. So the number one rule there is just always rule out the spine. So what does that mean? You do things related to the spine, and you see the impact it has on whatever extremity is hurting. It's your knee, your hip, your foot. You got pain in your tailbone. You got tingling into your hand. Whatever's going on in your extremity, what effect does moving the spine have on that area? And if we notice a relationship, if we notice we do something to the spine and symptoms get better in that extremity, and we didn't even move the extremity. You do a bunch of movements in your neck and your elbow pain gets better. Well, then I tell you, it's your neck. It's not your elbow. Though there are cases where where people have a certain percentage of their symptoms are related to an extremity, and a certain percentage of it is related to the spine. Well, you do the forces that you can in the spine, and then from there, you do what you need to do to treat the extremity. McKenzie method, there's things you can do from a movement standpoint in the extremities as well. It's a very important point, though. All right, so it allows you a way to self-assess. Self-assess is really the great thing about this, is that the same things that I do when I see the patient in the clinic for different sessions, you know, the initial evaluation and subsequent sessions, I'm teaching patients how to do that themselves when they're at home. So how do they look at their range? You know, a lot of times it's looking at range of motion. It's seeing, you know, is my range of motion limited? Is it painful? Then I have then the patient will do whatever home exercise they were given, and then they retest. They retest to see if their pain or their symptoms are better, worse, or the same afterwards. If their range of motion is better, worse, or the same afterwards. And that's a way to know if that exercise is helping them. If they notice, and I'm going to go into kind of a little more explanation of that in a little bit, but bottom line, and it's individualized. Okay, there's a lot of times there's a starting point with particular things where you see trends, where you see, okay, well, a lot of times patients will respond to this particular movement or exercise that I give them, but you have to be aware that every patient's different, and one exercise may work really well for one patient, um, but you give it to another patient and it actually makes them worse. And then within the same patient, they can come in one time and you get, you know, they come in with back pain and they get better with a particular exercise that you give them. They do it, works great. And then in the future, they come in and they need something else. And sometimes that exercise that worked for them, they use that in the future, it works great. But things change even within a patient. So cases can be different, even within the patient, you know, between different patients and within the same patient, what exercise you can do it. I've had patients where you start doing one exercise, they get better with that, and then things change, and now they got to do a different exercise. And anyway, it can be very interesting. But bottom line, it's really empowering in terms of the patient because it's giving you things that you can do, strategies to do throughout the day. Again, not feeling like we're trying to get rid of provider dependence. We're trying to create that patient independence idea. You want to be independent. You don't have to feel like you need to see me. Ideally, I can give you those tools, and you're able to take it from there. Hopefully, everyone's following so far. A lot of information. A lot of times when I see a new patient, I explain a lot of the stuff I'm explaining today. I'll explain on that first visit, and then I'll always say at the end, you know, it's okay if you know if you don't remember everything I talked about today. You know, we're gonna follow up in the future, and we like to reinforce concepts because there's a lot of information. I want you to feel informed, but it's okay if some of this stuff is a little confusing because it's a lot of information. So I want to talk about another concept called directional preference. Directional preference is really it's the movement that you can do that helps your symptoms get better. Okay. The idea is if there's a particular directional preference, if you move repeatedly or sustained in that position, you may exhibit a improvement in your range of motion, your pain, and your function afterwards, and it can be lasting. Conversely, you move in the opposite direction. Well, a lot of times the opposite direction of that movement that makes you feel better, you probably will get worse. You know, think about someone with I'll talk about lower back pain. A lot of times people with lower back pain, they bent over to pick something up and their back went out, right? If you had them bend over a bunch of times if they came in that day one, you had them keep bending over and over, they'd probably start to get worse and worse, and they wouldn't want to do that, right? Because but if they move the other direction, we may start to see that not only do they start to feel better, but they have less pain when they bend. And the same concept applies to the neck. You know, the neck, maybe they turn their head a certain way, and then their pain came on. If you keep having them turn their head to that way, the way that brought on their pain initially, you may start to get an aggravation in your pain. If you move them in another direction, their pain may be better, the range of motion may be improved, and they may be able to turn, to that direction that initially hurt. All right, so, they said there was no pain. Well, during a rehab exercise, should there be no pain? Should everything be pain-free? Well, I'll tell you, yeah, it's not the case that everything should be pain-free. Obviously, we don't want to cause, when we do an exercise, we do a movement, we don't want to cause severe pain. We don't want to cause emergency room pain. We're trying to get you to feel better, not to get worse, okay? However, especially when it comes to chronic pain, hurt does not equate to harm, okay? So pain is just a signal, right? The body is telling you something, okay? And so what we want to do is we want to use that signal and use it to the betterment of your symptoms to try to get you better. We want to take that pain that you're feeling and take that into account, notate it, understand what's going on, and then see what happens afterwards, okay? So what I like to use, I have the 10 to 20 minute rule here, okay? So if you're doing a particular exercise, if we're trying to find out what the right exercise is for you, and you start to get a increase in pain or a production of new pain, maybe your pain comes and goes, and when we do the exercise, you start to get pain in your back, and you're thinking, I came in with back pain. Why am I doing an exercise that hurts my back? Okay, it's kind of counterintuitive. All right. But a lot of times I'm thinking, okay, well, if we get pain in the area where you're hurting, if we do this exercise, you came in with back pain, we do the exercise, your pain in your back increases, or it produces the pain in your back. All right, let's keep that into account. Let's have you move through this exercise. I usually like to do about 10 to 15 reps. Don't want to just do one. If I just do one, I'm not sure. Is it aggravating you, or is it going to get better when you do more? Sometimes it'll get better as we do more, okay? And then we always want to look at the during and then the after. All right, so during, when you're doing that movement or doing that exercise, we're notating, is the pain increasing, is it producing? And then after you're done with a set of about 10 to 15 reps, I always ask my patients, okay, is this pain still increased? Is it remaining increased, or the pain that was produced? Do you still feel that pain now? 10 to 20 minute rule is saying if the pain that was produced or increased during the movement, if that pain doesn't remain increased, or remain produced for longer than 10 to 20 minutes, then you know what? I think that's okay. I would call that produce no worse, or increase no worse. Okay, it's basically, it stayed the same during the movement. It wasn't comfortable, right? It may have even increased your pain, but then afterwards you're back to where you were. That tells me it's okay, and that's a good guide for at home when you're doing the movement. You're saying, okay, you know what? I felt some increased pain when I did it, but now that I'm done with it, I'm about where I was before. I'm not worse. Okay, I can keep doing this exercise. All right. So we're still explaining our concepts here. I am going to show you some exercises, but I do the same thing with patients in the office. I don't want to show you an exercise until I've gone over some good ground rules. So just information for you to know, so you have some kind of basis to kind of interpret what you feel with an exercise. Centralization. All right. So what does that mean? Okay. In a nutshell, it's when symptoms are kind of further down, spreading to being more concentrated. All right, so I got the example here. Let's talk about classic sciatica. Get pain in your buttock or your lower back, and it kind of radiates. It goes out, maybe it goes down to your thigh, your knee, maybe it goes to your leg, your foot. if that pain goes from being all the way into your foot to now it kind of moves closer to the buttock, where you don't have pain in your foot, but now the pain's it's in your buttock. And I'm going to show you, a little picture here. See if I can use my mouse here. Okay. So let's say your pain's radiating all the way down to your foot. And you do a particular movement, and afterwards, you don't have any pain in your leg anymore. It's all in your buttock. Well, that's centralization. That's moving it, because the idea is, if it's irritating a particular nerve, the more irritated that nerve is, the further that pain is going to travel down that path of that nerve. So if we can do a movement that can take pressure off that nerve, that should allow you to not get as much spreading of the symptoms. Sometimes, I kind of talk about this here, sometimes that can result in an increase in pain. However, I have here, if it's closer to the spine, that's a net positive, meaning you got pain, it radiates all the way to your foot from your back. And you do an exercise, and you know what? Now, my foot doesn't hurt, but now my back really hurts. Well, I'm saying that's a positive outcome long term, because we're able to take pressure off that nerve, take the irritation off that nerve, and bring it to the source. Once we bring it to the source, that's when we can abolish your pain. Okay, so that's centralization. Hopefully that's making sense to people. Well, if we have centralization, we must have the opposite, which is peripheralization. So it's just the opposite. Okay, it's when symptoms go from kind of being more central to spreading. The example here, I've got neck pain that spreads to your hand, and I believe I have a picture here. Okay, so we have cervical radiculopathy, aka pinched nerve in your neck. Okay, you got irritation of the nerve or the joints in your neck, and it starts to spread, and you get pain in your hand. And that's kind of talking about, remember how I said rule out the spine? If someone's got pain in their neck, and they got pain or tingling or numbness in their fingers, would I start treating their fingers first? No, we want to see, is it coming from the spine? Sometimes people think they got carpal tunnel syndrome, and carpal tunnel syndrome is compression of nerves in the wrist. Okay, that's fine. A lot of people can have that. But what if that's actually compression of the nerves in your neck? If we try to treat the wrist stuff, we try to treat it like a carpal tunnel, we're not going to get much relief. We might still have the symptoms afterwards, because we're not treating the source. So peripheralization is spreading. Okay, so we don't want to peripheralize. We don't want to start spreading it and irritating that nerve more. If we're centralizing, we're kind of taking pressure off that nerve. If we're peripheralizing, we're increasing the pressure on that nerve, kind of making it worse when we're peripheralizing. All right, so this is a nice little visualization, kind of gives you a good idea when you're doing an exercise if it's helping, not helping, or making you worse. Or, I should say helping, not helping, or really staying the same. So green light in a traffic light is green means go. So a green light would be your pain or your range of motion is better afterwards. Or, as we talked about with centralization, symptoms are more centralized. So you start out, before you do this exercise, you've got severe pain in your back, and you can hardly move in all directions. Okay, you do the exercise, and then afterwards, your pain goes from severe to moderate. So that's a decreased pain, right? And then you can move more. You can bend down a little further. You can push your hips to the side a little more. You can arch backwards further. And you may have, sometimes only range of motion improves. Sometimes pain, improves. Sometimes both. And then the centralization, right? Pain's radiating all the way to your foot, and you do the exercise, and now you don't have pain in your foot. It's in your buttock. It's not in your foot. That's centralized, right? That's a green light. Green means go. Keep doing the exercise. It's helping you. Okay, that's a green light. You know, you see a green light, you don't stop, you just keep going through the light because it's green. Okay, so that's a response. A green light, that's a great response. We want to get a green light if we can. Okay, yellow. Yellow is kind of like proceed with caution. You know, you can go through the intersection. However, if it just turned yellow, maybe if it's been yellow for a bit, you know, you may want to stop, right? So this is just kind of keep an eye on what's going on. We may need to progress the exercise is really what it's saying, because things are staying the same. You know how I talked about, pain during a movement. You get an increase or a production of pain during a movement, and then afterwards the pain is the same. It's, say produce or increase, no worse. So if your pain increases or decreases during the exercise, but then afterwards it's the same. It's not better, it's not worse. It's a yellow light. Okay. Um, or your pain starts to centralize when you're doing the exercise. It goes from your foot to your buttock when you're doing the exercise, but then afterwards, you still got the symptoms in your foot. It's unchanged, or uh, you got symptoms radiating to your hand as you're doing the exercise. Oh man, I'm feeling it more in my neck, but then when you're done, it's still in my hand. So it's basically unchanged. You could also get pain spreading during the movement. It's in your back, spreads to your foot when you do the exercise, but afterwards, it's just in my back. That's that peripheralized idea, but it's all about that after. I'm really big on the after, okay? So we want to monitor what's happening when we're doing an exercise. We especially want to look at after. And remember that 10 to 20 minute rule in terms of if it's worse afterwards. Maybe the pain's a little worse for about a couple minutes, and then a couple minutes passes, and you know what? It's about the same. That's the yellow light. Okay, yellow light, if it's staying exactly the same, a lot of times I'll tell people, let's do the exercise more times, more sets, and see if we do more, does it start to turn into a green light? Okay, I go back to that green light, right? If we do the exercise more, because let's say we're doing a set of about 15 reps. Well, maybe you got to do more. Maybe you got to do more of the exercise. So that's why I proceed with caution. Sometimes you need to change the exercise, progress it. There's ways to progress exercises. Sometimes we can do the same exercise, but a progression is just doing more reps. Okay? Finally, we have our red light in the traffic light system. So this is where symptoms are worse. Range of motion or pain is worse afterwards, or the pain has spread afterwards. And this is in that, again, that 10 to 20 minute afterwards. It's been longer than 20 minutes. And you know what? My symptoms started as a moderate. Now it's severe after I did the exercise. Or I could bend a little bit before, and you know what? I can't even hardly bend at all now. It's even worse. My pain started in my back. Now it's in my foot after I did the exercise. My pain was in my neck. Now it's in my elbow. Or my pain was in my neck. It was moderate. Now it's severe. Okay. That tells me we want to change it. So a red light is the guiding principle at home for patients where symptoms are worse for 10 to 20 minutes afterwards. We need to change the exercise. And that's when I tell people that's when you discontinue. Just because I told you this is a good exercise for you to do and I evaluated it in the office doesn't mean that when you get home and you do it more, you might have a different response. So you want to listen to that traffic light system. Green means go, keep doing it. Yellow, keep an eye, maybe need to progress the exercise, maybe need to do more reps. Red, stop. It's not helping you, it's making you worse. We need to change it to make you better. Okay, so explained all our concepts. We explained, pain during a movement. Hurt does not equate to harm. We talked about directional preference. We talked about centralization, peripheralization, and we talked about the traffic light system. A lot of information again, but that's the guiding principles of McKenzie Method in terms of how to do it at home. The principles before I actually show you the exercise. Okay, so here we go. Standing back extension. Now I have in here kind of the kind of patient that typically will respond to this. However, every patient's different again. But this is what I see a lot. You know, patients that are worse with bending and sitting, they often will have, this is often a good starting point, because a lot of times, sometimes it's the movements that we're in throughout the day. Almost all the time I can tell you, people, a complicating factor is that whether it's their job or just their lifestyle, they're sitting too much. They're sitting all the time. So if they're sitting all the time, well, a lot of times we need to go the opposite direction. This is a standing exercise, okay? And it doesn't involve bending. It's where you put your hands behind your back, you put your feet shoulder width apart, you're gonna push your hips forward, and you're gonna arch backwards. And I think, oftentimes people will see this and they'll think, that looks like it hurts. That looks like it's gonna harm me. I'll tell you, the spine is very resilient, okay? More often than not, when I will prescribe this exercise to a patient, it often is very helpful. And a lot of times it's kind of the reassurance with that patient that, what, we just talked about the traffic light system, right? That's a good guiding principle. And the idea, hurt does not equate to harm. We want to see the effect when we do the movement. What happens afterwards? And so, this can be a very helpful exercise. Again, feet shoulder width apart. You're going to put your hands behind your back. You can use a fist. You can use this gentleman here is using the front of his hands. You can also use the back of your hands. You're going to put that kind of in, there's two bones on each side in your back, in that lower back area. You're going to push your hips forward, and you're going to bend backwards. And then you're going to see, if your symptoms and your range of motion, you're going to check those things. You see if symptoms are centralized or peripheralized. It's a hard word to say. Afterwards. Let's show you another one. Prone press-ups. Very similar to the standing back extension, except it's in a laying position. Okay. This can be very helpful if you have that like acute episode that just happened. I call it, when someone comes into my office, I call it a hot lower back. Someone just came into my office and they're just like bent over, just the back, quote unquote, wet out, right? Sometimes doing that, going back to that standing exercise, sometimes doing it in a standing exercise can be too painful because you're feeling the full effects of gravity. This exercise, it's like a push-up, except you keep your hips down. So I tell people, you put your hands underneath your shoulders like you're going to do a push-up. You're going to push up your upper body as far as you can go. Now this patient here, she's able to extend her elbows all the way. You might not be able to do that right away. And some people, they never can extend their elbows all the way, but you're going to extend them as far as you can get. Try to get a little further each time. If you are able to get your elbows all the way extended, then you're going to let a breath out and let your hips sag down like she's doing here. And that gives you that maximal end range position of doing the movement. And again, you're thinking, okay, is this going to harm me? We're looking at the traffic light system, right? We're looking at what's the effect afterwards. What effect does it have on us afterwards? And that's the guiding principle to determine if it's helpful or not helpful. And again, people that are bending and sitting, they're worse with bending and sitting. A lot of times this is helpful. Conversely, the knee chest exercise, it's the complete opposite of those last two exercises I talked about. This is often patients that are worse with standing and walking. So, especially there's a diagnosis called spinal stenosis. It's the typical history with that is the patient has either back pain or maybe back pain that radiates sciatica. It's brought on by walking, and it's relieved by sitting down or bending over. The typical history with that is this patient goes to the grocery store and they can hold the cart and they feel better. The idea is like when you're bending over, it feels a little better in a standing position. You're kind of leaning your weight on the cart. So this exercise can be helpful for that patient population. You lay on your back, you're going to pull both of your knees to your chest, and you're going to repeat that exercise. Okay? And not a sustained position, you're going to repeat it. Okay. And that's flexing your spine, kind of opening up the joints in there. And that can be really helpful. Patients with stenosis, pain brought on by walking and standing, you do this exercise throughout the day. It's a really great way of managing those symptoms. All right, I don't want to neglect the neck. We talked about the back a lot, but this is a good starting exercise for the neck. So how many patients, are looking at a computer prolonged, are sitting prolonged, are looking at their phones, and then they have that forward head posture, right? So this is going the opposite of that. It's called a cervical retraction. You're basically gonna have your chin even with the ground. I say like horizontal. You don't want to be looking up or looking down. Start just chin even with the ground. You're gonna bring your chin straight backwards. This one I can kind of do on the camera here. And then you're going to use your fingers to overpressure. Okay. Uh, Generally performed in a sitting position. You can perform it in a standing position as well, but you're just bringing that chin straight back and then overpressuring. And that's a good starting point for neck pain. Every patient is different, of course, but often this is where I like to start when it comes to neck pain. Okay. So kind of putting it all together, when we find the right exercise for a patient, McKenzie exercises, we generally are going to recommend 5 to 6 sets of 10 to 15 reps. People often ask, how many do I do? How often? 5 to 6 sets, 10 to 15 reps, or more as needed. The more as needed is a really important point here, though. If you find the exercise is really helpful for you, there's no upper limit for how many times you can do it. You can do it as many times as you want. Just follow that traffic light system. Now, conversely, if it makes you worse and it remains worse for longer than 10 to 20 minutes, discontinue. That's the red light. But I tell people this is your mechanical medicine. It's a movement you can do that can relieve your symptoms, and you can do it as many times as you want. You want to do at least that 5 to 6 sets of 10 to 15 reps. You want to get at least 50 to 60 reps, because you want to be able to see if you're doing enough reps to see the effect. If you don't do enough reps, we don't know. And we want to assess your pain, your range of motion, and your function before and after you do the exercise. That way, you have multiple ways to know if the exercise is helping. Let's say you do the exercise and your pain is exactly the same afterwards, but you check your range of motion, and guess what? The range of motion, you can move better. You're able to bend further. You can turn your neck further. You can look up more. You can look down more. Well, if you hadn't checked the range of motion, you would have thought maybe it felt the same. Function as well. Are you able to get in and out of the bed? Are you able to get in and out of a chair? Are you able to walk, stand? Various, turn your head. Things that normally would have aggravated you, are those things feeling better, less painful? Is your pain less frequent, less intense? Those are ways to know if it's helping you, ways to assess. We want you to be really good at assessing yourself. Same things that I would do in the office. When in doubt, follow the traffic light system. Green, keep performing. Yellow, keep going, but check to see if things are better or worse. See if you need to progress it. Red, discontinue. Okay, I think I got right to the questions right in time. I'm happy to answer any questions people may have.
Right, so let's just give people a few moments to formulate their questions there. I'm just wondering, as a lot of our audience is a little bit older, for the prone press ups, it looked like kind of like the yoga cobra position to me. If someone can't get all the way to the floor, is there another way to do that exercise?
It's a great question. So you can do it on your bed. Most people have a bed at home. Most people. And so sometimes it's something where maybe your pain's worse in the morning when you wake up or something. You can turn onto your stomach and just get some of those press ups in. Yeah, so a high table, even a couch if you had to. A couch can kind of be a little softer sometimes, but I find people can do it on a bed just fine.
Okay, great, thank you. Someone else is asking, with the neck exercise, bringing the jaw back, it sounds like it's for a patient that has a TMD condition, and the person says perhaps the TMD condition can also radiate to carpal tunnel syndrome. Is that something that you're familiar with?
Okay, so that's a good question. Okay, so if someone has pain in their jaw, symptoms in their jaw, doing that exercise potentially could be aggravating if they're having like temporomandibular joint dysfunction, TMJD. Okay, I always say everybody has a TMJ on their right side and their left side. There's a joint on each side. There's two joints. And if you have irritation of those joints already, doing that movement could potentially aggravate it. It might not, but it could be a complicating factor. Now, someone could have, remember what I was talking about, centralization and peripheralization, okay? Someone could have pain in their neck that irritates a nerve and it radiates to their face, and they get pain in their jaw. It's a great example of ruling out the spine, okay? Let's say you think it's your jaw that's causing the pain. You do this exercise it's moving your neck, and your jaw pain starts to get better afterwards. Well, then you know what I'm thinking? I'm thinking it's coming from your neck. And there's another part of that question was carpal tunnel syndrome, like symptoms in your hand or whatever. Okay. So carpal tunnel syndrome is basically just compression of the nerve, the median nerve in the wrist. However, if you get irritation of nerves in your neck, you can get similar symptoms in your hand. You could get symptoms along the same area. And so, again, you want to see the response of moving the spine, what effect it has on the extremity. Hopefully that answered that question.
Okay, well, and if they want some clarification, feel free to enter something else. Again, I'll just give people another minute to think about questions. And maybe I'm asking for a trade secret here, but I'm just wondering, when someone comes in with, say, a pain in their foot or something like that, how do you determine that it actually is related to something that's going on in, say, their spine or some other area of their body?
Great question. Okay, so one of the biggest things is the history. Okay, so the better worse section is really big on that. Okay, let's say someone has pain in their foot. Okay, what makes it worse? Is it worse when you're walking, you're running, you're using your foot? Is it worse when you're sitting? When you're sitting, you're not really using your foot. You're kind of the foot isn't really under pressure. That makes me think more it's your back. So what makes it better or worse? What are the things that consistently, if there are things that consistently make it better or worse? Then you perform some range of motion, some tests for the foot, if it's the foot, if it's an extremity, whatever the extremity is, evaluate the range of motion of that, evaluate the range of motion of the spine as well, whatever spine area might be involved. If it's a foot, look at lower back. If it's the hand or something, we're looking at neck and upper back typically. You evaluate those things, then you move the area, you try a particular movement. Typically, you'd be moving the spine first, because remember, we want to rule out the spine first. You move the spine, have the patient do something or you do something with them, and then you see what effect does that have on that extremity. If the extremity gets better and it wasn't even moved, the extremity wasn't moving, the spine was moving, right? We're thinking spine. Now, if the extremity stays exactly the same, then we're thinking, okay, maybe we have ourselves an extremity thing, and then we can proceed with care. If the extremity is affected, we should try treating the spine first.
Okay. All right. Well, thank you so much for your time. It looks like that's all of our questions for now. Again, we were able to record this program. So if you're watching the recording of this, you can ask for the links that I'm going to be sending out to the registrants later tonight. Lots of contact information and a few other resources as well. So again, thanks to everyone for joining us tonight. Thank you so much, Dr. Leon. This was really great information. And
Thank you.
we will hope to see everyone at another program soon. But until then, stay safe and pain-free, we hope. Good night.
Yeah. Thank you.